Morning and welcome to Research Over Coffee. I'd like to start by acknowledging that we are in Mi'kma'ki, the unceded ancestral territory of the Mi'kmaq people. We are all treaty people. We also acknowledge the histories, contributions, and legacies of the African Nova Scotian people and communities who have been here for over 400 years. I'm Laura Hines-Jenkins, Director of Government Relations at Dalhousie University. Research Nova Scotia and Dalhousie University designed this series to provide a medium to bring together Nova Scotia experts and government decision makers to discuss issues of relevance to our province. Our intent with this series is to profile the scope and scale of research expertise housed in our province and to facilitate connections between the people tackling Nova Scotia's greatest opportunities and the experts working at the forefront of these areas. As Nova Scotia works towards a universal mental health system, understanding the prevalence and burden of mental health issues on the broader population will be key to developing and implementing preventative and responsive mental health services. I'm pleased to introduce today's guest, Dr. JianLi Wang. This morning, he'll take us through his research on the role of big data analytics in informing the prevention of mental health problems in our population. Dr. Wang is a professor in the departments of community health and epidemiology and psychiatry in the Faculty of Medicine at Dalhousie University. He is the CIHR Canada Research Chair Tier 1 on Health Data Science and Innovation and is an affiliated scientist with Nova Scotia Health. After Dr. Wang's presentation, we'll be taking questions using the Q&A function of this webinar. I will now turn it over to Dr. Wang. JianLi?
Great. Well, thank you very much for the introduction and good morning, everyone. Well, mental health problems are so prevalent, and I believe many of us know someone with a depression, anxiety, or other mental health problems. And also we know there's no one is immune to a mental health problem, no matter who you are and where you live. And in the past 20 years, we have made a significant investment in mental health and mental health services. But today, we still think our mental health system is in crisis because many people couldn't access to service when they're in need. And we don't have sufficient number of mental health professionals. So in the next 20 minutes, I would like to share with you the current literature about why prevention is important to address this crisis and how big data analytics can be used to assist prevention and decision making. But first, I would like to show you this slide. Which is how the disease burden has changed in other health disciplines, like the cardiovascular disease. This slide shows the trend of heart disease mortality between the 1950s and 2021. And in different countries, and Canada is here in the middle, which is this greenish line here. As you can see from here, there's a significant downward trend from 1950s to 2021 in basically all the countries, including Canada, for the cardiovascular disease mortality. Whereas for the disease burden related to mental disorder, this one is the prevalence of major depressive disorders in the United States from 2005 to 2015, which is flat. The top one is the prevalence in females, and the blue one is the prevalence for in males. So which are flat. There's no change between these 10 years. It is the same in Canada because we examined the data, the population health data collected by Statistical Canada. We found that in 1994, the annual prevalence of major depressive episode was 4.9%. and it was 4.8% in 2002. And in 2012, it was 4.7%. The differences was not statistically significant, which means, despite the significant investment, we haven't observed a measurable change in the disease burden associated with a major depression. This is not only happening in North America, it's the same across the world. And these are the results from the Global Burden of Disease study, the GBD study. I believe many of you are familiar with this one because this is the largest and the most comprehensive effort in quantifying disease burden over time. And many countries have used the GBD results to inform their health policies. And this one shows the prevalence of any mental disorders in 1990 and 2019, which is 30 years apart. And if you look at here, in 1990s, the prevalence of any mental disorders was 12.6%. 30 years later, it was 12.3%. And for anxiety disorders, which is one of the most prevalent mental disorders, in 1990s, it was 3.8%, and it was the same 30 years later. And for depressive disorders in the 1990s, the prevalence was 3.5%, and 30 years later, it was 3.4%. So this is a drastically different pictures in comparison to the cardiovascular disease mortality trends we just observed. So the question is, why the disease burden associated with mental disorders has not changed? There are many factors contributing to this, and one of them is we haven't done enough for prevention. Now let's go back to the heart disease mortality case. We observed the significant reduction in cardiovascular disease mortality, which is this blue line. During the same time period, we also observed a significant reduction in the population blood pressure, which is this red line, and also cigarette smoking reduction, and also the cholesterol level reduction in the population, and all risk factors for cardiovascular disease. So smoking, blood pressure, and cholesterol level are the fundamental determinants of a heart disease. So now there's a consensus that the significant reduction in the mortality is not only due to the implementation of thrombolysis or stents in the clinical practice, but also the widespread use of statin like in the population to lower your cholesterol level, the better hypertension control, and cigarette reduction. So these are the prevention efforts. These prevention efforts successfully shift the exposure curves in the population, which lowered population risk of heart disease. So compared to the cardiovascular disease prevention, we haven't done enough in prevention of mental health problem and mental health promotion. This is one of the contributing factors to the unchanged disease burden associated with the mental disorders, and we call it prevention gap. So how the big data analytics may help to address the prevention gap. There's a couple of applications of the big data analytics. Number one is large population health data could help us to identify risk and protective factors for mental health problems. So the risk of the disease can only be reduced if we can change the population exposure to these risk factors and promoting protective factors. So epidemiological study have have identified a large number of factors that are associated with the risk of mental disorders. And this is a systematic review of these studies, which was published in the Journal of World Psychiatry. And this review, list several some factors that are common to a number of mental health problems. And these factors include the social economic status and poverty, the work stress, and childhood adverse events, as you may know, the physical illness, and some unhealthy health behaviors. So these are the factors that are commonly shared by many mental health problems. So to reduce the risk of mental disorders, so we need to reduce the population exposure to these factors. Otherwise, it would be difficult to observe a significant reduction in the disease burden, overall, like what we observed for the cardiovascular disease mortality. So second application of the big data analytics for the prevention gap is, the big data can be used to develop advanced tools for high-risk intervention strategy. The rationale of the high-risk intervention strategy is that, we have our resources are limited. So instead of applying the resources to the whole population, and we may target individuals who are at high risk of having a health problem. So we can deliver personalized intervention to this subpopulation so that the intervention can be more effective and the resources can be more efficiently used. And these strategies can be applicable to the prevention of a mental health problem. Because for mental health problem, we know there's no clear cut in between the disorder and then versus non-disorders. Like most of us usually move back and forth between the healthy and reacting stage on this graphic. But in the community, there's a small proportion of people can move from the healthy stage all the way to the illness stage here. If we have a tool to be able to identify this subgroup of population who are at high risk, then we can intervene early so they don't have to develop a mental health issues at all. So this is the high risk. Intervention strategy. But for the tool to identify high risk individual, you need to have the large population health data to develop such tool. And this type of high risk intervention strategy has been successfully implemented in the heart disease heart disease prevention. One success story is the Framingham risk score, and the Framingham risk prediction model was developed using the data from a study called the Framingham heart disease study, which was conducted in a small town called Framingham in the United States. That was back in the 1960s. And with these two and with this model, and the clinician can calculate based on your lab test and your clinical information, the clinician can calculate your risk of having a cardiovascular disease over the next 10 years. And, as a matter of fact, last month when I did a virtual consultation with a primary care physician, and he also calculated my my risk of having a heart disease using the Framingham risk prediction model. So it now has become a routine clinical practice in North America and also in Europe, and it has underpinned several health policies for prevention of heart disease. So basically, inspired by the Framingham risk prediction model, we also developed a risk calculator for major depression in the general population using the population health data collected by Statistical Canada. So with this tool, we can apply, we can be used by anyone in the community who say you're not in the episode of depression based on your exposure to a key set of risk factors. And these two can calculate your risk of having a depressive episode over the next 4 years. And many of the users in our research reported that this piece of information is very informative, helpful, and anyone in the community should have access to such information, because it really makes them think about their where they are in terms of their mental health and what they can do, what they should do to improve or maintain their mental health. At the beginning, we mentioned there's always an imbalance between the demand and supply in mental health services, which created issues of wait time and disparities in service access. Like several other provinces, Nova Scotia also adopted a tiered mental health services model, 5 tiers like this one. The bottom two tiers are focused on like a self-help, screening, primary care. That's where the primary prevention and high-risk intervention strategies could play a role. And the top 3 tiers are for the specialty mental health and addiction services, which are highly in demand. But matching clients to the appropriate level of care in a timely manner is a complex task. This is where health data analytics can help and play a role. And I can share with you a success story in this area, which happened in the UK about the first episode of psychosis. The psychosis is a cluster of psychotic symptoms that are shared by several severe mental illness, like schizophrenia, bipolar disorders, or major depressive disorders. The only promising strategies for psychosis is to shorten their duration of untreated psychosis through the early identification and early intervention. But the problem is the psychotic disorders are difficult to be recognized by non-specialists. So there's always like underdiagnosis and delayed diagnosis, or the delayed referral and treatment for this in this population. So these patients have to go back and forth in the system that lead to poor prognosis and significantly higher, more health expenditure. So to tackle these issues, the researchers and the clinicians in the UK, in South London, they developed a prediction model for first episode psychosis using their electronic health record data in the secondary mental health care setting. And then they embedded these risk calculators in the electronic healthcare system. So whenever a patient's information is entered, and then the system will automatically calculate the risk. If the risk is high, and the warning message will be sent to the physician, treating physician, and the physician will decide whether or not a thorough assessment is needed, or whether a referral to specialist is needed. So with this system, they are able to identify a number of patients that are at high risk, and make the early, timely referral to specialists that they cannot do otherwise before. And with this early intervention, early identification, patient would be able to see specialists earlier, get treated earlier, and have a better prognosis and a better outcome. And also, naturally that save a significant expenses for the healthcare system. So this is the success story in the mental health services delivery. And in addition to the utility at the individual level and healthcare system level, the health data analytics can also be used to inform population health planning, like to provide evidence and knowledge about the disease burdens and the population mental health and well-being, the distribution of social determinants of health, and how they are varied by different region. And not only that, how not only about their status, in the past and the current status, but also how this disease burden then gonna look like over in the future, like what the GBD study could offer. For example, with the historical data, researchers can, developing the models to predict or to forecast the mortality rate in the population in the next 20 or 30 years. And we also embarked on the honors project that use the health administrative data and the population health data to estimate the population risk of a suicide in the population over the 10 years. So this type of data analytics could help decision makers identify the community that are at higher risk so that they can mobilize resources and complex interventions to these areas and at the right time in advance. And so there can be, more proactive rather than being reactive. At the same time, so they can use big data analytics to simulate the potential impact that these complex interventions can achieve. So all these applications, need to be supported by large, high quality data. And fortunately, in Nova Scotia, we have such a data infrastructure. For example, we have the health admin data at the provincial level. We also, like the Nova Scotia Health and IWK, also hold a number of databases, clinical databases. We also have the government also have the data about the justice and social assistance, education, and mortality, etc. And furthermore, we also have the access to the population health data collected by Statistical Canada, which Nova Scotia is a part of it. So to wrap up this short talk, and we see the mental health problem, is associated with considerable disease burden, and compared to we lag behind other health disciplines in terms of prevention of a mental health problem. Big data analytics could not be only used to identify high-risk individuals to discover new therapeutics, but also could be used to enhance the efficiency of mental health services delivery, and also to inform population health planning. And we have the high quality data here. Nova Scotia I think it's in a unique position because of its population size and the existing health the data infrastructure. So if we can integrate these data sources well, and we can do amazing things that cannot be done in other provinces. So those are what I would like to share this morning. Thank you very much for listening.
Thank you very much. I'm Stefan Leslie. I'm the CEO of Research Nova Scotia, and I'll be hosting the Q&A portion of the session. We've got about just between 15 and 20 minutes for questions, and you'll see at the bottom of your Zoom screen the Q&A button just down there right at the bottom. And so if you have any questions, just pop them into that, and I'll manage the discussion from here. Just to get things started, first of all, really interesting presentation, and a couple of things that emerged out of that. One was the discrepancy between the incidence between male and female. And so as you're developing the algorithm to evaluate preventative strategies, how does it accommodate, or does it accommodate, the different approach, either physiological or otherwise, between men and women?
Yes, for the risk prediction model for major depression, we developed, what we did is use the population health data collected by Statistical Canada. But because of these, the sex difference we have been observed, for a long time, so we developed the sex-specific prediction models. So one for males, one for females. They have some overlap. They have shared some common fact predictors in the model, but there's also some sex-specific factors in the model as well. So of course, for those, the predictors that are overlapping in both model, their coefficients or their weights are different, so that we can apply the model for male and female differently. Of course, they also have a different threshold when we try to determine or decide a high risk.
So when you were building the model, and I understand the inspiration for cardiovascular, you mentioned smoking, blood pressure, cholesterol. Those three are all kind of objective numbers that can be measured. And then when you had your slide that presented all of those risk factors, I didn't count them, but there looked like there were about a dozen or so. And many of those are much more qualitative, or there's a lot of judgment. So how is it that how do you build a system that is able to ingest that kind of discrepancy in data, and perhaps issues around data quality or different collection methods, maybe that they change over time and on different timescales for different people? Like, how is it that you can accommodate all of that to build a system that provides that predictive capacity?
That's a really good question. I think that's one of the most important issues in psychiatry, in mental health. Like in the cardiovascular disease, and we can do a blood test, and we can see our, we can see our cholesterol level. We can measure our blood pressure in a more objective way. But in psychiatry and in the mental health, that diagnosis are basically determined by question. When you ask patient questions, and then based on what they provided, the information they provided, and you determine whether or not this individual has such a mental health problem. It's the same in the population health survey data for all to screen or to identify whether or not the individual to have a mental health issue. So we have to use a kind of a structured diagnostic interview, which is all solely based on the patient's self-report. So that's one of the limitations in psychiatry, in mental health problem, because we don't have a reliable lab test indicator to pinpoint a specific mental disorders. But for our research to develop the risk prediction model, we have to use whatever the Statistical Canada collected in their survey. And we build this model. We're not just to throw all the risk factors or variables into a model and see here, that's the model. We have to validate it and make sure it performs well, because we build a model, we have to find a different sample and see if we use the model to predict what happened in the new population, does it work? This is called a validation process. And that's what we did. And we found that I think in the new population, the new population risk was, I think it was the same 4.8% in overall, but there's always a sex differences. We validated in male and females separately. And the model calibrate the data extremely well, which attests to the accuracy and the quality of the prediction model.
So on that, was that applied to the overall population levels, or does it provide predictive capacity that's appropriate at the individual level? Because you mentioned the automated detection,
Yeah.
where presumably it brings in data that's either self-reported or through a primary care provider,
Yeah.
and then it presumably provides feedback to say
Yeah.
there's treatment or some sort of response is necessary. So when you talked about validating your data, was it that it managed to estimate appropriately the overall level, or did it provide that kind of effective feedback at the individual level?
Both, like both the population level and the individual level. So we want to make sure that, what we predicted and they're reported, are consistent. So it applies to both population level and the individual level.
One other question related to how things are constructed around the support for children and mental health issues. Do things have to be adjusted, given some of those risk factors would be perhaps the coefficients may be a little different, or the balance would shift through age? Does what you've built, is it kind of universal and those things need to be adjusted, or is it really targeted to an adult population?
It was the model we built is mainly for the adult population, because the population health data collected by Statistical Canada is only for the individual age 18 and above. So if we want to build similar things for children and youth, we have to do a separate study, because the risk factors and for having a specific mental health problem in children and youth would be different from the adults. So I would highly recommend, if we want to build a risk prediction model for children and youth, we have to do a separate study in that population. They're so different because of their developmental stage and the physiology, physiological changes they are experiencing. They're so different. So we have to look at the different factors.
Question here around the impact of the pandemic. Of course, that everyone has that in the very recent memory. Do you have any assessment, or have you managed to consider how either that effect would have had on some of those percentages at the population level or at the individual, adjusted those risk factors, or had to get built into the model and into the predictive model that you're working on?
Yeah. Well, I think during the COVID period, and what people mainly concerned is about, whether or not they have depression right now, or if they're having anxiety at presently. So if you're looking to try to assess whether or not you're kind of like a more depressed or anxious than usual, there have been, the validated tools like PHQ-9, the GAD-7, which you can use to assess how different you are in compared to the usual time. But the model we developed is not about whether or not you have depression right now. It's about your risk of having depression in the future. So, which means you don't have depression right now. How is your likelihood of having depression in the future in the next couple of years? But assessing your current mental health status is important. I think what is more important is what you can do after you think you are at high risk or you feel depressed. So I think before, when we are in during the COVID period, it's difficult to access access services in person, and what you can do is do it online. There's always timing issues. I think self-help and self-management is going to be a very useful strategy. There have been a list of evidence-based or evidence-supported strategies for self-help and people can use. And we have developed a depression risk communication program based on this risk prediction to say, if you're at a high risk of depression, so what are your, like say, the issues that trigger you become more stressed? And what do you do? What are you doing to manage this stress? And these are the list of evidence-based self-help strategy, which one would be feasible for you and to manage your stress. So we have developed such a depression risk communication program. And in the next couple of months, we're going to do a national randomized control trial to see if such a program could really reduce the risk of having a clinical depression. That project is supported by the Canadian Institute of Health Research.
Okay, so just so I understand how you took that point. So by providing the kind of feedback to look at what essentially the exposure risk would be given the assessment across a number of different factors, perhaps really what that means is that the entry point is lower down on that pyramid that you showed, where individual and community response perhaps may be effective in reducing the probability, so reducing that kind of risk factor. So the other half of this, as you've just said, if I understood correctly, is providing those tools to understand how to diminish that risk.
Exactly. And the tool and the communication is mainly to help people who are at high risk to manage their stress and to lower their risk so they don't have depression at the first place.
Right. In developing this and providing the feedback, how do you manage concerns around both stigma and kind of privacy and security of the results if you're providing this kind of insight at the individual level as opposed to validating population level statistics? Then presumably people could be concerned about the impact should their employer find out or their insurance company find out, maybe even their family. So just wondering how you manage those sorts of issues within this work.
Well, we've been doing those through a series of research projects, and what our communication with the research participants basically is all, one-to-one. So between our research staff and with the research participant, either through telephone or the online, the video conferencing. So we keep the confidentiality, and try to to protect their privacy. So when we send them the assessment report, this report always go directly to these participants. So we will not tell their family member about we're doing such and such a study and to show their health report. And in that way, I think the participants were very happy with us about the way we communicated with them. And as a matter of fact, and the participants are very, I would say, active in kind of like sharing their stories with our research staff, and more than beyond what we expected. So I think the participating this research and also sharing their story, I think that maybe is helpful for their own mental health, because they get their emotion out. And of course, the whole process of confidentiality and the privacy protection is our priority. So we just keep it between our research staff and the participants.
So given how that was built, is there a potential for selection bias among the population that are participating? Because if there is the possibility that those who would be more open, just as you've described, would that possibly lead to skewing the data around their particular predisposition to answering some of those more qualitative questions? Or is the sample size large enough that you can have the confidence that both at the population level and for individuals of different characteristics or different places in life, different social determinants, that it's robust to all of that?
Good point. Highly possible. Because when you do research, and only those individuals who are interested will participate. in your research. And for our randomized control trial across the country, we recruited the participants not just from one province. We recruited across the country. So we call these people, using their either cell phone number or household number. We explained our, research, and only those who provided the consent will participate. And it's always possible to have selection bias because only the certain people will participate, and also the reporting bias. But later on, after we collected our data, we compared the demographics of our participants with the population health survey conducted by Statistical Canada. The demographics are similar, but the possibility of selection bias, you cannot entirely exclude it, because we don't have a sampling frame for all the individuals who are at high risk in Canada. So we just can see our samples are similar with the general population sample in terms of the demographics.
Right. So in just the last couple of minutes that we have, any advice based on the research that you've done and presented this morning, in advice or insight that you'd provide to policymakers or the development of response more generally? So that's not just policymakers, but maybe also communities, families, individuals, on how best to use or make use of this kind of research.
Well, I think, first of all, we need to make this research accessible to everyone in the community. And I think that will need a collaboration between researchers like myself and also the service planner at the health authority and the policymaker. So, we work together, and we can raise the awareness about, say, we have such a tool available and it has been validated. And so the people can know there's such a tool and the research evidence that exists, so they can access to the knowledge, to the evidence. And I think the most important thing is we need to provide the evidence-based information about what they can do once they find out that they're in a high risk stage. And so through that, we hope to, like say, lower the population risk overall, and also to prevent, to have less people to develop a depression, to develop anxiety, so they don't have to go to the hospital, at all. So in that way, we can make our healthcare system more sustainable.
Well, thank you. We're rapidly out of time. A really fascinating conversation. I'd like to thank you. JianLi Wang has really provided really useful and interesting insight this morning. I'd like to thank everyone who participated this morning and providing some of the basis of the questions for the discussion today. This is our final session in this year of Research Over Coffee. So I want to thank everyone who participated, and to ask you to keep your eyes open for future topics. And again, once again, Dr. Wang, thank you very much. It was really interesting, and I wish everyone a great rest of your day. Thank you.
Thank you very much. Yeah, thank you for listening. Yeah, have a good day, everyone.
Thank you.
Bye.